This is case L3 Ccta A103. The history is that of an 84-year-old woman who has chest pain and shortness of breath. She has known coronary disease and is status post placement of a stent in the right coronary artery approximately 1 year ago. We're going to start with general inspection of the study. Here we are at the base of the heart. Here's the aorta, pulmonary artery. As we move down, left atrial appendage appears to be intact. Left atrium suggests that it may be at least mildly dilated. We can make somewhat of a reasonable check in this area by making a measurement and pretending to be an M-mode echocardiogram. Get a measurement here of about 44 millimeters, upper limits of normal at 40 millimeters, so it's mildly dilated. Proceeding further down, we can see that there is some plaque in the aorta. There also is a relatively prominent mitral annular calcification in this area, the classic C shape of MAC. The aortic, thoracic aorta does have moderate plaque in the region. The left atrium was dilated. The right atrium in these levels, although it's difficult to measure, also suggests that it may well be also dilated. We now look at the cardiac dynamics, specifically left ventricular function. This is the horizontal long axis view. We can set this in motion. Appears to be normal to even hyperdynamic function of the interventricular septum. Apex, lateral wall, we can see the predominance of the mitral annular calcification, but it does appear that the mitral valve leaflets are opening normally. Here's a vertical long axis view showing again excellent function in the anterior wall, apex, and inferior wall. And finally, returning to the short axis, we have also excellent function with no evidence of clear left ventricular hypertrophy with normal function in the septum, anterior wall, lateral wall, and inferior wall. We commence looking at the coronary arteries by beginning with the left main. The ostium of the left main appears to be normal. There is some eccentric calcified plaque in the left main. This is mild to moderate and, in my opinion, would be considered non-obstructive disease. We now focus on the left anterior descending. There is clearly eccentric calcified plaque rather diffusely in these vessels. This would be probably called the D1, which appears to be generally normal. If you look, however, if you want to call the next vessel up the D2, this appears to have either obstructive disease, possibly could be occluded, but it's very unclear, and you can't determine antegrade from retrograde flow in the adjacent vessel. Moving down into the distal left anterior descending, there is clearly some eccentric plaque in these areas. If we look at this a little bit more carefully, switch to an MPR view, there's really nothing here that suggests that this is clearly obstructive disease. It's at least moderate in severity, with the remainder portion of the left anterior descending appearing as normal. We next look at the left circumflex artery. This is a non-dominant vessel that clearly has some ratty disease. There is a small ramus intermedius coming off in the very proximal segment. Difficult to evaluate because of the vessel size. Nothing clearly obstructive, however. As we proceed down looking at the body of the left circumflex, you have to be cautious of the mitral annular calcification and the overlap. But if you rotate around the vessel, you can actually see that this vessel appears to be not showing any severe disease. There may be a small narrowing in the proximal portion, but nothing suggesting obstruction in those regions. Follow out into the obtuse marginal, which appears to be relatively normal. We now turn to the right coronary artery. This is the ostium. There may be a suggestion of some mild plaque near the ostium, but if you rotate around, you can see that the ostium is clearly not compromised. So we proceed down the vessel. This is the stent that is very large and clearly patent. Stents are traditionally very difficult to assess with respect to luminal characteristics. You need to at least return to an MPR view. In the MPR view, in this situation, you can see that you can actually see very nicely inside the stent. And if you follow it along all areas, this clearly shows no evidence of obstructive disease and is widely patent. Following the remainder portion of the right coronary artery, there is some eccentric, non-calcified and calcified plaque in the area near the crux. However, if you look at this area a bit more carefully, there really suggests nothing of obstructive disease. Turning to the distal portion, there is some eccentric plaque, nothing again that appears to be compromising the lumen. Do return here to the posterior descending artery, which is perhaps going to be one of the more concerning areas as we get down into this segment. There is some equivocal or borderline disease that possibly could be obstructive in the portion of the ostium of the posterior descending coronary artery. In summary, then, we have an 84-year-old gentleman who's had a stent placed in the right coronary artery 1 year ago. The stent is now widely patent with no evidence of obstructive disease in that segment. However, he has had chest pain and shortness of breath, and there is equivocal to obstructive disease at the ostium of the posterior descending from the right coronary artery. There is also equivocal or obstructive disease in the left anterior descending with subtotal or obstructive disease in the proximal portion of a very small second diagonal.